Today, we are going to concentrate exclusively on the diagnostic challenges of BPS. Conundrum means a puzzle or a challenge, and we chose the topic as diagnostic conundrum to highlight the fact how challenging it is to arrive at the diagnosis of bladder pain syndrome. To start off the session, I would like to invite none other than the architect and the chairman of the GIBS, Dr. Rajesh Taneja. For those of you joining us today, Dr. Taneja is the pillar of GIBS, a senior urologist and transplant surgeon at Apollo Hospital, New Delhi, India. He has taken it upon himself to spread the awareness of bladder pain syndrome across India. Over to you, sir, for your deliberation on diagnosis of bladder pain syndrome.
Uh, Thank you very much, Dr. Tamil Selvi. And can you see my screen now?
Yes, sir.
Okay. So thank you very much, Gibbs, Cheshta and Deepthi, and Swati Spentos for giving me this opportunity to talk about the diagnosis of a suspected case of ICBPS. It is very important that we talk of so many things, but the basics need to be emphasized. And that is where, if your eyes do not know, if your mind doesn't know, your eyes will not see. So your eyes will see only when you are prepared. That means if you have a high index of suspicion, only then you can make a diagnosis. And diagnosis of BPS-IC is sometimes like making a hole in thin air. You don't know what you're doing. That is how we started off. But nowadays, this statement is actually 25 years old. Nowadays, we know a lot of things much more clearly than what used to be 25 years ago. So when I was being trained at All India Institute in 1991-92, I was taught that it doesn't exist in India, and nobody had seen it. And everybody used to think that, okay, if somebody makes a diagnosis of ICBPS, that means either he's dumping the patient to something. So there used to be an entity in the medical college by the name FDS, frequency dysuria syndrome. So nobody knew more than that. And that is how a patient was dumped to a corner. Nobody would look at it. And the patient would keep coming back again and again to the urology department. And we used to think it is just a subjective feeling of the patient. And I do not know how many patients who suffered, and we were responsible for this disservice to the patient. But then when I came into practice, I realized though it does exist. It is indeed there. So how do you look at it? So when I'm sitting in my chamber, I see a patient who walks in with a wad of files and records and multiple doctors and years of suffering, and perhaps so many surgeries without relief of symptoms. And everybody has told them that this patient has got nothing. You start thinking that maybe this is the patient who requires or who deserves some interest, focused activity of your mind so that you can make a diagnosis on this patient. More often than not, these patients have a functional overlay, which is primarily not the disease, but it is a secondary reaction to the disease that they have been suffering from. But we choose to pick up the functional overlay, label it as a functional patient, and dismiss the case. But that's not true. We need to find out why in the first place this patient has this functional overlay. And since we dismiss these patients, they lose credibility at home. Their children, their partners, their family members, everybody starts thinking that this patient is perhaps creating a fuss and doesn't suffer from anything. It is only in her mind. And so they start getting distancing from her, and they start, condemning these patients so that they get isolated and they start having suicidal thoughts. So if a patient walks like that to me and talks about pain, I need to find out what is this pain. So if you go to the Oxford Dictionary of Medicine, you will find that there is a pain. Pain is described as an unpleasant sensation. So that unpleasant sensation could be pain as it happens after an injury, or a discomfort, or a burning sensation, whatever it is a nociferous stimulus which is difficult to continue with. And one would like to get rid of this nociferous stimulus at the earliest. So when we talk of pain in such patients, we need to ask them, what kind of pain or discomfort do you have? Now, patients do not come to us with a term called pain. They will say in colloquial languages, pressure. Sometimes they will say that somebody has put a weight in my pelvis. Somebody will say somebody has put a fire in my pelvis. So you need to extract the history and define that nociferous stimulus. So when we talk of bladder pain syndrome, it has to be pain or discomfort in lower abdominal urogenital area of more than 3 months duration. So anything which is less than 3 months is perhaps, you need to give another diagnosis to that, or at least think of giving another diagnosis to that. And then which is worst on full bladder, along with one or more urinary tract symptoms. Now, initially, when we started off in, say, 1990s, there was this criteria where they said that bladder pain syndrome occurs beyond only above 18 years of age. But nowadays, we know that no age is excluded. And in pediatric setup also, we have a lot of patients who present with bladder pain syndrome. So what are the urinary symptoms they talk of? They talk of frequency and urgency. So if they say, I have to go to washroom very often, you have to ask them, okay, you are sitting with me and suppose there is no washroom, what will happen? So the patient says, no, I just want to go to the washroom and I can't resist. So you ask them, what will happen suppose there is nothing around? Will you leak or will you have pain? If the patient says, I'm scared that I will leak and soil the seat, that means it is an overactive bladder. If she says, no, the pain will be intense, it will go to my head. Most of the time they say, sir pe chad jata hai, go to my head, and it will make me uncomfortable. So that is the bladder pain syndrome, where holding urine is disturbing the whole biology of the individual. It starts from the bladder but affects the whole body. Similarly, urgency. So you tell them, they say, we want to go and pass urine. You tell them, what is the urgency? Again, they may say that if I don't pass urine, I will have intense pain. If they tell you that, obviously they have given you the diagnosis. So the diagnosis starts the moment the patient starts opening her mouth. They start answering your questions. Coming to dysuria. Now, dysuria is difficulty in passing urine. So what is the difficulty in passing urine? Is it a difficulty which is pain? Is it burning? Or is it something else? So I will talk about dysuria in my subsequent slides. I've already talked about pain and heaviness and pressure. So coming to dysuria, we normally equate dysuria with burning. There may be pain, there may be scalding sensation. So all that is considered as part of dysuria if you go and look at the dictionary. So you are going to ask them, they say there is burning in the urine. You ask them, okay, what is the burning? Suppose we are sitting here and talking to me. Do you have burning right now? If the patient says, it is always there in the urethra, it is always burning, it is making me difficult to sit, I want to lie down because I will sit on the chair and it is burning, perhaps she has vaginitis. Perhaps she has urethritis, because there is an inflammatory pathology in the vulva which is causing burning and which is not making her able to sit in this chair completely comfortably. So suppose we tell them, okay, when do you think is the burning going to be? Suppose she says, I don't have burning right now, but when I go to pass urine, I start having burning. So that is a different situation. So we need to understand what cycle of urination does she start having burning. So we need to ask these questions. One of the questions that you ask is, okay, you're sitting here, do you have burning? If she says yes, it is vaginitis, urethritis. If you ask them, okay, if you don't have burning, when will the burning start? So she will say, I don't have burning because I've just passed urine before coming to your room, but I will soon start having burning. So then you have to ask them, if you start having burning, what do you do? Suppose you are at home and the burning starts, what do you do? So they will tell you, I go to pass urine. When you ask them, why do you go to pass urine? They'll say, because after passing urine, the burning reduces or disappears. Now, in initial cases, the burning disappears. But over the period of years, the fixation to burning is so much that the patient is not able to differentiate between the burning on full bladder versus burning on empty bladder. So they will be reluctant to tell you that yes, burning reduces after passing urine. So you need to be careful when you're talking about burning sensation. Suppose they say, I have no burning now, I will have a desire to pass urine. I go to pass urine, and the moment I start passing urine, the burning starts. And it stays on for 4-5 minutes or maybe 10 minutes after I've finished passing urine. That is again an inflammation of the vulva. Urine contains acid. If there is urethritis, if there is vaginitis, if there is a senile urethritis, senile vaginitis, or pre-senile changes, sometimes they are difficult for the naked eye to examine. But if the patient gives this typical history that after passing urine, there is burning sensation which stays for 10 to 15 minutes in the vulva, that means there is a urethritis or vulvitis or vaginitis. And of course, if there is a sense of incomplete urination, that means there is inflammation of the trigone. So you have to dissect the symptoms of the patient before you go further. Then coming back to the character of the pain. So as I mentioned, that there are so many terms, vernacular terms that they will use, and you need to be careful in actually looking at these kind of terms, and you should be familiar with them. Some of the more intelligent and literate people will come and tell you that the pain is coming from bladder. So when you tell them, how do you think it is coming from bladder? Then they will tell you, okay, it is because when I pass urine, I feel better. So it must be my bladder which is causing pain. So distribution of pain would be lower abdomen, perineum, vulva, clitoris, inner thighs, lower back, and anus. Now, if you look at this distribution, this is the very same distribution that happens in pelvic inflammatory disease. So if there is a pelvic inflammatory disease, of course, bladder is a part of pelvis. Of course, if the bladder is inflamed, it will mimic something like a pelvic inflammatory disease. So only difference is when you say that if the bladder is full, it causes pain, and when the person has passed urine, the bladder is empty and the pain has reduced. That gives you an idea that this may be related to bladder. One more point here about the clitoris. Now, many patients tell me that when the bladder is full, there is a pricking sensation or a sensation of something cutting or biting, like a pin prick at the clitoris. Now, this is a very typical symptom, which is a neuropathic symptom coming from the bladder. And this happens in males, they present as pain at the tip of penis, a burning pain at the tip of penis on full bladder. So these are the description and distribution of pain which you must understand. And somehow, which is not written in books, but we find in our experience, a lot of these patients will tell that there is burning sensation in the anus or perianal area on full bladder, which reduces. I really can't explain why, apart from the fact that they share the same same neuroanatomy. So they share the same nervous anatomy from the spine. The same segment is innervating both these structures, and that is why they have this kind of pain. So I just talked about this. If the pain is related to maturation cycle, we know that it must be what, as I've just explained. Another thing is when the patient says the patient has nocturia, that means she wakes up from sleep to pass urine. You need to ask a very simple question. When you wake up from sleep, is it the bladder sensation which is waking you up, or is it the pain that wakes you up? If it is the pain that wakes you up, then of course we are dealing with bladder pain syndrome. But if she says, yes, I wake up because the bladder is full, then we need to look at whether it is an overactive bladder, whether it's a small capacity bladder, or there may be another reason for it. Then dyspareunia is a very important symptom. Why is it important? Because it gives a clue as to what is the site of inflammation. So for example, in cases with bladder pain syndrome with say Horner's lesions, it is a deep dyspareunia. So there is nothing superficial. So if you do a pervaginal examination in these patients, the anterior fornix is tender. The base of the bladder or the trigone is tender. So that is where the deep dyspareunia is reported. But if the patient says she has superficial dyspareunia, then we need to look at whether there is a pelvic floor disorder or whether there is a superficial infection in the vulva, urethritis, and vaginitis. And that is how you can differentiate a bladder pain syndrome from a gynecological condition. So I'll skip this slide. So one must ask, what is the previous history? For example, whether there has been a pelvic surgery, which the patient may not come forward on her own. For example, previous surgery for a twisted ovarian cyst, or an ectopic pregnancy, or a tubectomy, or a tuboplasty. We really don't know. Any of these surgeries is an intervention and change in the anatomy. And these changes, they are associated with scarring, and scarring of the nerves and the organs getting tethered to an unusual situation can give rise to pain. History of stone disease, of course. There used to be a teaching in Bailey and Love, those kind of books at that time, where people used to diagnose a urinary stone by PV examination, by feeling the stone at the uretrovesical junction. So obviously, urinary stone disease, and it gives a pain and frequent urination at the same time, which is very close to something which is a bladder pain syndrome. I have talked about pelvic inflammatory disease, history of tuberculosis, pelvic radiation, infertility, and endometriosis. If somebody has been treated for endometriosis, we must ask these questions. They are very relevant, and sometimes patients forget to tell you these. And of course, if there is a history of neurological disease, so many times patients have been treated for bladder pain syndrome where they actually had neurogenic bladder. So once you make up your mind that yes, this is coming from bladder, you need to understand what could it be because of. Maybe it is because of allergies, if there is a history of allergy, if there is a history of bronchial asthma, or if there is a seasonal cough or sneezing, drug allergies, then of course, if there is an allergy which is manifesting in respiratory tract or sinuses or skin, it is quite possible that there is a manifestation of the same allergy in the bladder. So the bladder gets urticaria too. So there may be, this is how you have to think. So if the patient has allergies elsewhere, most likely she's ingesting something, and sometimes patients are able to tell you that I get flare of symptoms when I have a particular thing. So there may not be a acidic pH or something else, but it may be just an allergic phenomena. Then in patients who say they have obstructive symptoms, it may be due to pelvic floor spasm. In certain series, it has been reported that almost 80% of these women who are diagnosed with bladder pain syndrome have pelvic floor spasm. So they have a dysfunctional voiding. The bladder pushes, but the sphincter or the pelvic floor does not open. So we need to be careful, and it gives us a clue that yes, if the patient says, I keep sitting on the pot, I keep trying to pass urine, it doesn't come. When I get up from the pot, it suddenly starts passing urine. So this is a dysfunctional voiding, and we all should be careful, and we should ask these leading questions from them. And as I described earlier, if the patient says burning character of pain, that means it is suggestive of neuropathic pain. And these are the patients who would be treated with tryptomar or something like that, which will help them. So there are other things, like recently, we are going through a COVID era. So recent change of diet. Many patients have started having decoctions and concoctions and kadhas and other things in their diet. They think they are healthy, they cause immunoboosting, but actually they are irritants to the bladder, to the stomach, to the colon, and they keep discounting these side effects till such time that they come with really bad symptoms. Some people, especially middle-aged women, would like to lose weight, and they take excessive green tea or herbal tea, and they get a flare, and they get something like bladder pain syndrome, which needs to be clearly defined. And this is the easiest bladder pain syndrome to treat. Patients, some of them will react to dark chocolates. And we need to ask them, were you taking something? Are you taking something which you were not taking earlier? And they may just come up with an answer. And that is how you clinch the diagnosis. If there is a recent drug treatment change, which is an unrelated disease, for example, in diabetics, if there is an addition of glycosuric drug, which increases the flow of glucose through the urine, then there is a bladder irritability. And this is a real thing. And I have stopped this medicine and the patients become much better. So we need to look at the associated comorbidities. All these are listed in the book. I would not like to list them. And as far as the examination is concerned, we start with the gait of the patient, the mental state. We need to make a note of all these things. And scars of previous surgery. So many times the bladder has been found tethered to the anterior abdominal wall. And that is how when the bladder fills, it gets pulled to one side and she has pain. And you need to be careful. We have seen few patients who have been suffering just because of the scarred bladder to the anterior abdominal wall. And of course, we need to look at any masses or any suprapubic tenderness, whatever it has to be noted in your notes. Local examination, you are the better person than me in local examination of a pelvic examination of a female. And that has to be done as written in the book. Every step needs to be done. Unfortunately, I've come across the gynecological examination notes from many doctors, and I have to send them to Dr. Ranjana. I send all my patients to Dr. Ranjana Sharma, who is there in the panel, because she knows exactly how to document, and that is what helps both of us. And if there are any myofascial bands or trigger points, they need to be seen. And if there is a doubt, we need to look at the focused neurological examination. So definition of Gibbs for ICBPS is pain or discomfort in lower abdomen or urogenital area of more than 3 months duration, which is worst on full bladder, along with one or more of the urinary tract symptoms with or without standard stigmata of cystoscopy. And we need to exclude any discernible pathology other than this. To investigate, we need urinary diary. We need to look at the intake of fluids, both type and amount, and urinary frequency volume. So each time how much urine has been passed, that has to be recorded as per the time. And for further investigations, urine routine is very important. It should be the first morning sample. If there is presence of leukocyte esterase, nitrite, or pus cells, then it has to be sent further for culture. If any of these is not, if none of them is present, there is no infection, and we do not look at the culture that way. Urine cytology is done only if there is microscopic hematuria. And ultrasound of KUB and ultrasound pelvis is must, because without that, we should not be proceeding further in these patients. There should be a residual urine which must be mentioned in each ultrasound KUB. And one can do intravesical lignocaine test in case there is a doubt. You can put 20 ml of 2% lignocaine into the bladder, and there is almost immediate reduction in pain. There may be false results in case of inflammatory pathology like urinary tract infection, radiation cystitis, etc. So to sum up, we need history examination, urine routine examination, and ultrasound. If in doubt, intracycle lignocaine test, and then we can clinically score and scale and proceed further treatment. Thank you very much. I